Thank you for asking me to come and speak today. This is a recording of my presentation because I'm really sorry I'm not going to be able to attend in person. I know it can be a bit annoying, so here's a copy of my presentation that I pre-recorded. So I'm going to be talking about sexually transmittable enteric infections amongst men who have sex with men. I'm going to try and show you the history and the evidence around these pathogens, and then we'll end on a quick case. And I don't have any conflicts to declare. So traditionally, fecal-oral pathogens are transmitted via the fecal-oral route using vectors such as fluids, fields, flies, fingers, and this is very much a model from the developing or low-income parts of the world, where these organisms then get into our food and water supply and we can become infected. However, over the last 70 years, there has been evidence that there is another dynamic that these pathogens can transmit, which can avoid these vectors using sexual contact. So it was really Selma Dritz who is my hero. She was a public health physician, epidemiologist, who in the 1980s did some really groundbreaking work amongst gay men in San Francisco, showing that then HIV, although it wasn't known that it was a virus called HIV, was sexually transmitted amongst these large sexual networks of gay men in San Francisco. But before this work, in the 1970s, she was very interested in enteric pathogens, and she did some really seminal work looking at these organisms, so Shigella, hepatitis A, and Entamoeba histolytica in particular, showing not only that these organisms were being sexually transmitted amongst gay men in the San Francisco area, but the incidence rates were increasing significantly. And she also described a small case series of 4 individuals who had typhoid fever, where there was no story of any travel amongst any of the men in these studies that she presented, and therefore she postulated that these organisms were being sexually transmitted. And so over the last 50 years, we've seen increasing reports of enteric pathogens being sexually transmitted, particularly amongst gay men. So Selma Dritz, and a little bit earlier there was a small case series in Manhattan of two male couples who had, inverted commas, relations with each other. That's what the paper says, and they all had Entamoeba histolytica giardia. And then the HIV epidemic probably changed the epidemiology of these infections. It certainly reduced the number of reports, apart from a significant outbreak of hepatitis A in 1990. But then in 2000, certainly the advent of antiretroviral therapy, which was probably not serendipitous, that we saw this increasing these rates of all of these pathogens. And at the same time, of course, we've got HIV prevention strategies. We've got increasing use of antiretrovirals to prevent transmission of HIV, either because we're treating individuals living with the infection adequately, or we're giving antiretrovirals to HIV negative people to prevent transmission. And of course, this changes the whole dynamic and epidemiology of STIs in this group, including its sexually transmissible enteric pathogens. And of course, now we've got the challenge of doxycycline PEP, which I wasn't going to talk about a lot because I suspect that Farid might talk to us more about this, but we're going to be seeing increasing consumption of antimicrobials amongst this group, which might impact the transmission of enteric pathogens or antimicrobial resistance. And I guess that's the other thing to say, that we've seen emerging, particularly amongst Shigella and to a lesser extent Campylobacter, possibly Giardia and Entamoeba, increasing rates of antimicrobial resistance. And this is particularly important in Shigella, which I'll talk about in a little while. So just to summarise the syndromes that these pathogens cause, hepatitis A, of course, causes an acute hepatitis, so men will present with jaundice, fever and diarrhea. Giardia and Cryptosporidium, although there's very poor evidence for sexual transmission of cryptosporidium will cause an enteritis-like picture, and then the other organisms will cause proctocolitis, causing diarrhea, fever, and sometimes it can be bloody. So who are these men who have sex with men who are part of sexual networks where these pathogens are being transmitted? What are their characteristics? Well, we've done quite a lot of work in Brighton looking at this, and we've come to the conclusion that these men fit a particular demographic. They tend to be older, often living with HIV, particularly those men who are not taking antiretroviral therapy. Over the past decade, that we're seeing more HIV negative MSM with these pathogens who are using HIV PrEP. Although there's significant reporting bias, there probably is a signal that these men live in urban areas, they're part of urban sexual networks, and of course they use geosocial mobile phone applications such as Grindr to meet sexual partners. And their behaviours, they have often more than one sexual partner, are engaging in oral anal sex or rimming, oral sex and condomless anal sex. They engage in sexual activities which increase the risk of fecal contamination, such as fisting, such as scat play, which is playing with feces, or using toys for sex, using sex on premises venues which are often dark and a bit grotty, therefore transmission of these organisms can increase, and of course the intersectionality of chemsex or use of recreational drugs to facilitate sexual behaviour, particularly these days crystal methamphetamine or GHB. Previously we saw MCAT and ketamine in this space. And then co-infections such as chlamydia, gonorrhea, syphilis and other STIs, but most notably people living with HIV. And I suspect there's been a lot of confusion about the intersectionality of HIV in this world, because is it because they're immunosuppressed or is it about behaviour? And I think as time goes on it's all about behaviour rather than immunosuppression, which may have played a part in people with salmonella and possibly Campylobacter previously. And antimicrobials need a mention because we're seeing transmission of extensively drug-resistant organisms here, and on the background of an increase in consumption of antimicrobials in this group because of antimicrobial use in sexual health clinics, access to antimicrobials amongst this group, and doxycycline PEP. And these organisms can cause significant morbidity. So we know that certain strains of E. coli, possibly Shigella, will cause the hemolytic uremic syndrome due to sugar toxin production. There can be significant neurological and immune-like phenomenon, although rare, such as reactive arthritis. Shigella can cause an encephalitis, and of course acute inflammatory demyelinating polyneuropathies or Guillain-Barré-like syndromes, which can be triggered by Campylobacter or some of these other pathogens. And certainly some of the Shigella subtypes, Flexneri in particular, can lead to quite severe phenotypic disease. So in our series in Brighton, 50% of people with Shigella Flexneri in the outbreak in 2013-14 were hospitalised, and they caused significant dehydration because of the diarrhea, and those who experience other social determinants of health and other health conditions may experience severe morbidity, if not mortality, from that. So let's talk through the infections, and I'll highlight some of the interesting points as we go through. So there's been 3 large outbreaks of hepatitis A in men who have sex with men over the past 50 years or so, in 1990, in the early 2000, and then this outbreak, which was quite significant in 2016-17. It was a global outbreak amongst MSM of just 3 circulating strains, very similar, they're all 1A, and they were all linked to large events where gay men would congregate, such as pride events, particularly the one in Madrid in Europe, and men who were susceptible to hepatitis A because they've not been vaccinated, because of changes in vaccination policy and austerity, experienced quite significant hepatitis. And I think we had more than 100 cases here in the UK I'm pleased to say we didn't have any in Brighton because we've always been really good at vaccinating against hepatitis A, but we can see a study that we performed about 4 years ago showed that those MSM who are susceptible to hepatitis A tend to be younger and not born in the UK. And so we've got to focus our vaccination programs on those people who don't necessarily come forward for vaccination or fit their bill. So Giardia is a parasite which causes a duodenitis and fat malabsorption. Giardia is a zoonotic condition, and it's endemic in some parts of the world, but generally not in high income settings. Case series on the left from Kim Holmes's group was the first sexual network that I'm aware of that was drawn like this, and these men all were sexually related to each other by the arrows, and they all had Giardia. And then since then there's been a case control study and some other smaller studies showing that Giardia is more common in men who have sex with men, and it's probably a low degree of endemicity among certain networks associated with condomless sex and anal contact. So Shigella is the most important of all the infections I'm going to talk about today because of the magnitude of the problem and the extensively drug-resistant isolates that we're seeing currently. These are two studies from the UK which are very important. The top one is Shigella sonii and the bottom one is Shigella flexneri, very similar in terms of the observational studies. In these studies we can see that more than 50% of these men received oral antibiotics of varying types, and I think that is significant because clinicians are faced with Shigella and the reflex is to give antimicrobials, and as you can see looking at this list of antimicrobials, they're not necessarily appropriate. We've done some work in Brighton looking at antimicrobial resistance patterns in Shigella amongst men who have sex with men, and this is what we found, that over time, very similar to what was seen in Neisseria gonorrhea, Shigella have collected antimicrobial resistant genes to all of these antimicrobials. So started with cotrimoxazole, macrolides, quinolones, and more recently cephalosporins. So we have really good knowledge of the antimicrobial resistance genes we're in Shigella and other enteric pathogens that drive antimicrobial resistance. Most of these genes live on plasmids, which is important because of the rapid transmission of these antimicrobial resistance isolates. I think the most important are the ESBLs, particularly CTXM27, and I'm going to show you some graphs showing CTXM27 progression. So if we could just focus on the left hand side of this slide first, this is an outbreak in Victoria, Australia in 2020, and you can see the phylogenetic tree at the bottom. We've got this isolate here which is affecting a large group of men who have sex with men, a couple of people who are identifying as women here, and as you can see they've all got ESBL, and importantly they've all got CTXM27 which confers antimicrobial resistance against cephalosporins. Here very beautifully we can see this is Kate Thorley's paper from UKHSA. This is Shigella isolates in men who have sex with men, and this is flexneri, and over time from 2015 to 2021 not only has CTXM27 got in plasmid containing CTXM27 got into Shigella isolates, but we can see the proportion of individuals with Shigella in the UK has changed from 6% to 43% of men who have sex with men, and I believe that now UKHSA are seeing more than 50% of isolates are from MSM. And then if we look at Shigella sonnei, slightly different picture, we're seeing more sporadic outbreaks rather than endemicity. But in 2020, we've got Shigella sonnei without CTX-M27, and then this outbreak from 2021, which is ongoing, and there was a recent alert about this ongoing outbreak with ceftriaxone resistance. So I think we need to understand a lot more about this particular ESBL and extensive drug-resistant Shigella to think about how we develop control mechanisms, and part of the problem is the microbiome and the gut. So these very clever people have been doing some interesting work with this Kate Baker from Cambridge, Holly from UKHSA, and Claire from UKHSA. You might know Claire from your work because she's a microbiologist, and so they've previously shown that this plasmid containing CTX-M27 can pass from Shigella to other Shigella sublineages and other pathogens such as E. coli. We've done a study in Brighton where we've taken rectal samples every week from asymptomatic men for a period of 3 months, and we haven't published anything yet, but one of the things that we've shown is that not only does this particular genetic marker for ceftriaxone resistance pass to Shigella and E. coli, but it also passes into the microbiome and sits in the microbiome for several weeks and then can transmit to other organisms as they're passing through. So now let's just talk about some of the other pathogens. So Campylobacter, most of the evidence comes from the US, where there's been several outbreaks in Baltimore, Washington DC, and Quebec, affecting small groups of men who have sex with men who were particularly unwell. They've also shown significant antimicrobial resistance. We did see some quite severe campylobacteriosis in men living with HIV who were admitted to hospital. And so I think the message about Campylobacter is there is limited transmission in MSM and there's antimicrobial resistance. E. coli, I think, is a more puzzling picture. If you look for E. coli amongst MSM, you will find it often asymptomatic, and we're talking about diarrheogenic strains, which I put on there. They're often associated with living with HIV and other bacterial STIs. Our study in Brighton has shown a huge number of E. coli strains amongst asymptomatic men, but the significance of that is currently unknown. And then, of course, Salmonella or typhoid, Salmonella species, including typhoid. So I told you about Selma Dritz's study. There's been a couple of other small studies, mainly in the pre-HIV era, but also similar to Shigella and Campylobacter, with it's about the behaviours such as oral anal sex, hand licking, and the demographics around HIV. We see far less Salmonella and Campylobacter than Shigella, and this is probably related to the infectious dose required for transmission. Therefore, these are not particularly efficient sexually transmitted infections. There's been quite a lot of work, as you can see, 6 studies looking at asymptomatic men who have sex with men and estimating the prevalence of these pathogens. And this is a systematic review that we've just completed in Brighton looking at this. We used a random effects model to estimate the prevalence of these organisms. The problem is we don't really have any baseline. We don't know how many non-MSM have these organisms sitting in their microbiome or their gut at any one time. The only asymptomatic control that I'm aware of is a Danish study, and in the Danish study all of these rates are very similar apart from Shigella, which is significantly increased in this group, which kind of makes sense because I think that's the one that's truly being sexually transmitted to a significant level. So the parasite Entamoeba histolytica is important, of course, because it causes extraintestinal disease and can be asymptomatic. Therefore, is different to the other pathogens in that asymptomatic people should be offered treatment, and we should be thinking about their sexual contacts in this space, because Entamoeba is definitely sexually transmitted. There's most of the evidence, however, comes from Asia, where probably endemic entamoeba spilling over into men who have sex with men networks. There's a very small amount of evidence that Cryptosporidium may be sexually transmitted, and of course Cryptosporidium's different again in that the cysts of Cryptosporidium are chlorine resistant, so it gets into our drinking water and happens here. It happens in Brighton. I lived in Australia and worked in Sydney for a year, and definitely there were times where the swimming pools were closed because of Cryptosporidium outbreaks. And we know from small studies that Cryptosporidium is possibly associated with certain similar demographic and behavioural factors that I talked about earlier. So the final infection I just want to talk about is intestinal spirochetosis, which is confusing because it's difficult to diagnose. You can only diagnose it on a biopsy. I put the spirochete, the human pathogenic spirochetes on the left hand side. So we've got Treponema pallidum that we all know and love in my world, leptospirosis, Lyme disease. These are brachyspira organisms that are often present in asymptomatic people. They call this brush border, but some people do get symptoms including proctitis, but often a diarrhea. And there are some series of studies looking at men who have sex with men, and the associations are similar to Shigella and the other bacterial enteric pathogens, particularly with HIV, co-infection with other infections, and sexual behaviour that increases the risk of fecal contamination. So, in clinical practice, we are seeing people with sexually transmissible enteric pathogens. What do we do with them? I think what's the most important thing is that we prevent clinicians from giving empirical antimicrobials and even giving sensitivity testing antimicrobials, because the evidence for that is poor and the potential harms are large, and we should be reserving our antimicrobials to those who need it, such as those who are in hospital with sepsis. But because this is a sexually transmitted infection, we need to do some look backs as sexual health clinicians. So in the British guidelines that I chaired last year, we made an expert opinion decision that we should go back 4 weeks for all the infections apart from Entamoeba, and we should only be testing sexual partners if they're symptomatic, unless they've got Entamoeba histolytica. So in summary, I've been telling you about sexually transmissible enteric pathogens. These are neglected diseases, and they are similar to other neglected diseases. There is intersectionality with drug use, with poor access to healthcare, with poverty, and with minority groups such as gender minority groups, sexual diversity, and racial and minoritized groups. And you could argue there's a lack of research, and certainly doing some systematic reviews looking at these pathogens, it's really difficult to find quality research that can inform and empower further research or guidelines. So what can we do? What can I do? So we've written some toolkits with UKHSA and BIVA and BASH with my colleagues there, Gowrie Godbolt and Laura Waters, who was the chair of BIVA, alerting clinicians, certainly working sexual health around Shigella, making sure people take adequate samples and don't use antimicrobials without discussing with microbiology or you guys. Tristan Barber, who's a consultant at the Royal Free, and I have written some e-learning for enteric pathogens. We put together some guidelines to help clinicians make decisions around testing and antimicrobial use, and of course the study that we've set up in Brighton with my colleagues at UKHSA and the University of Cambridge. Hopefully we'll find some informative results that will inform this space a bit more. So I've got a case for you if we've got time. Here's Jake. He's 30 years old. He had chlamydia proctitis a couple of months ago that was treated in the sexual health clinic, and he presented to his GP with 4 days of diarrhea, and you've got a positive PCR for Shigella, and the GP phones you for advice. So with your partner, person sitting next to you, I want you to spend 2 minutes thinking about what advice you give to the GP. What else do you think the GP needs to do? What treatment should be offering? And anything else you want to ask or find out about this individual. And because this is pre-recorded, I'm going to finish, and these are all the wonderful people that I work with, mainly on enteric pathogens. And the QR code is to our national guidelines, which maybe you want to zap and read at your leisure. Thanks for listening.